on latest developments in neuro-ophthalmology. I have my co-chair, Dr. Kaman, and we're waiting for Dr. Satoshi, but we'll start with the session. So our first talk for today is going to be on the use of OCT for differentiating between optic disc edema from pseudoedema. And we have Dr. Stephen from Denmark who's going to call. Stephen.
But Stefan is not here yet. Oh, is it? It is. Sorry.
Well, I think I'm no problem. Good morning, everyone, and thank you very much for the kind invitation. This is by far my favorite topic, so I'm very happy to be invited to speak here today. And with the first session, I think it's okay. Maybe I should just use this one. Okay. So just start by a very short quiz. I have 6 photos here. They look very much alike, but this was 6 different patients, and one of them has elevated intracranial pressure. Is it number 1? Just raise your hand. Number 2? None. Number 3? Oh, 1. Number 4. That's the classic. Yeah. Everyone thinks. Number 5? There's a few ones. And number 6? 1. All right. This is a buried optic disc drusen. This is a tight crowded disc. This is a tilted optic disc. This is buried optic disc drusen. This is a crowded disc. And here you have the tumor. Clement, you got it right. All right. Okay, so this was just for saying that it's very hard for the subtle disc edema to separate by means of fundus photos alone. So if you have a severe papilledema, what is known as Frisén grade 3 to 5, it's pretty easy to detect. But and of course, if you have no papilledema, it's also easy. But a subtle papilledema, grade 1 or 2, is very hard to detect, and it can be the only sign of a serious life-threatening condition. So what about OCT? I have 3 major questions. Can we use OCT to differentiate papilledema from pseudopapilledema? Can OCT, it's like you can call it an in vivo biopsy of the optic nerve head. Can it provide us more information about the relationship between structure and function? And can AI help improving speed and accuracy? So I'll go through these 3 questions here today. So first question, can we use OCT to differentiate the two? In other words, to establish what is the cause of the blurred disc margin. So what is the cause? And what is the anatomical explanation for the buried optic disc margin? Why do we see this phenomenon, and how do we differentiate among etiologies? First, the what. What is the anatomical explanation for blurred optic disc margin? The answer is called peripapillary axonal distension. It can be abbreviated PAD, and there can be some interstitial edema. So this has been described from many years ago, that surrounding the optic disc there's this axonal distension in case of optic disc edema. And it's present in all sorts of optic disc edema, also in pseudoedema, like in optic disc drusen. These PAD, they can be visualized in vivo using OCT, and here we term them FARMs, peripapillary hyperreflexive ovoid mass-like structures. We've described these in 2018, so we've known them since then. So this is how a FARMS looks like. It's peripapillary, it's hyperreflexive, it's in 2D section, it's ovoid, it's mass-like, and it's a structure you can see. It's present in all kinds of optic disc edema. This is in papilledema before the pressure goes down. When the pressure goes down, it goes away. This is in drusen, here in Nyon, central versant vein occlusion, an optic neuritis attack, and after the attack, when it goes away, and a tilted optic disc. So there's 2 signs to look for to make sure it's a FARMS. First, it has to be peripapillary, so you have to be able to see Brooks membrane underneath the structure, and then you have this ski slope sign. You have the retinal layers above the FARMS that get diverted upwards like a ski hill. So a FARMS, it starts in the nasal part of the disc, and it can extend all the way surrounding the optic disc like a donut or a torus. So you can actually do a little video in some of the OCT machines where you can follow the FARMS all the way surrounding the optic disc. Since it is a torus structure, you can also measure the volume of the FARMS, which can be quite revelating, as it can give you a lot of interesting information, as we've shown in this paper. So that was the what, and now to the why. So why is it blurred? So there are two situations. Either you have a true disc edema or you have a pseudo disc edema. In case of a true disc edema, you have the pad or FARMS, but you also sometimes have the interstitial edema. And the pseudodisc edema, you only have the pad and the FARMS. These are the ones causing the pseudoedema. It's not the drusen themselves, it's the pad or the FARMS. The most common causes of true disc edema is compression, ischemia, inflammation. And the most common causes of pseudoedema is optic disc drusen, a tilted disc, or crowded disc. These two, the raised intracranial pressure versus the optic disc drusen, those are the most common ones that you need to distinguish between. So it's kind of interesting if you look at FARMS. These are the blue bars here in age. This is for more than 400 patients we've looked at. And when you have FARMS due to optic disc drusen, you see 80% of the below 10 years old, they have actually FARMS. But then when you get older, the FARMS goes down. And when you're above 80 years old, you don't have any FARMS left. However, the visibility of the drusen is very low when you're young, but it gets more and more visible. And when you're very old, you can see all the drusen. So this is why if you see blurred disc margins in an 80-year-old, it usually is true disc edema. So finally, how do we differentiate between a subtle papilledema and a pseudopapilledema? Of course, you need to talk to the patient, ask for symptoms that are relevant to the clinical case. Also, you need to examine the patient. Here you include ophthalmoscopy, looking for signs of true papilledema, and you do OCT to look for signs of pseudopapilledema and what are called telltale signs of true papilledema. We'll get to that. So the classic ways of looking for true papilledema on ophthalmoscopy: the small vessels disappearing at the margin, the engorged, elongated, tortuous veins, the hemorrhages, and the absence of spontaneous venous pulsation. Here is important to note that 10% of normal individuals do not have spontaneous venous pulsations. But if you see it, you know that the pressure inside the brain is below 19 centimeters of water, which is very reassuring. So how do we look for pseudopapilledema on OCT? We came up in the International Optic Disc Drusen Consortium. We came up with some guidelines for how to distinguish drusen on OCT, and the most important thing is that it needs to be a hyporeflective structure, and it usually has a hyperreflective membrane, which is most pronounced anteriorly. You see the FARMS also again. So the good thing about using OCT for detecting drusen is it can be used in all patients, whether they are superficial, as here, or they're deep, and whether they are large, small, or clustered together in conglomerates, or whether you're a very young person, such as this 3-year-old, and able to sit still for the time it takes to take the OCT. So enhanced depth imaging OCT is now considered the gold standard for detection of drusen. In this study, we compared it with the other means, ultrasound and autofluorescence and photos. It was superior in both sensitivity and specificity. So we came up with the guidelines for how to scan using OCT. You can take the QR code if you want to. You go to a website. We also have it for swept source OCT. And what is most important is that if you want to be sure that you capture all the drusen, you need to do a very dense sectioning, at least 97 sections. If you do 97 sections, there are 30 microns between each section, and you're sure to pick up all the drusen. Of course, sometimes they're so big that you only need to do one section. But if you want to be on the safe side, you need to do a lot of sections. We do a radial circle scan also. That's the one you use for the farms volume calculation, and of course a macular scan to see any degeneration. How about the peripapillary RNFL thickness? Is it useful for differentiating like buried drusen and disc edema? Not really. Here is an example of a 28-year-old with idiopathic intracranial hypertension. The RNFL is 136, and here's a 10-year-old with drusen, and the global thickness is 226. Usually, if it's above 300, it's true edema and not drusen. So, what are the signs of true papilledema on OCT? You can do a peripapillary OCT, a macular OCT, and an optic nerve head OCT. I just mentioned this, what's called the rule of 300. If it's above 300, you're sure that it's papilledema. If it's 100 to 300, it could be pseudopapilledema. You do the macular OCT, and in acute cases, look for fluid. Subretinal fluid is indicative of true disc edema, and in long-standing cases, look for GCL thinning. And you do the optic nerve head OCT. You have these very nice peripapillary folds and wrinkles that are seen on en face OCT. I'll show you a more clear picture of this in the next slide. And also these small fluid pockets that are surrounding the disc, they are very indicative of true disc edema. So this is just from a study we just published recently, where you can see these en face photos with very nice folds also in a very high resolution. And this is just to show that if you have the right equipment, of course you can get these beautiful images, but usually you can get it on en face OCT as well, and it's never seen in true disc edema. And I'm very happy to present a new sign also that we just presented 2 weeks ago at NANAS, and we call it the farms up. The study we did, we call it farms up. The reason why we call it farms up is because it's the layers above the farms, up from the farms. And this sign, in this case, it's pseudo disc edema, and here's true disc edema. So we call it the snake sign. And the reason is if you see here in the pseudo disc edema, it's like a garter snake. It's the same size of the retinal layers here as the retinal layers here. But if in true disc edema, it's like a cobra snake. It gets this large head like the cobra snake. So if one of your residents come to you and ask, doctor, is there a true disc edema in this? You say, have you done an OCT, and look for the snake sign. So it's a very visual way of looking directly and getting an idea of whether there's a true disc edema or not. All right, so rundown of the blurred disc margin. The reason for it is the pad or the farms. Why do we see this phenomenon? We see it either in true disc edema or pseudo disc edema. How do we differentiate? We do it by clinical evaluation, including ophthalmoscopy and OCT for pseudo disc edema and telltale signs of true edema. Second part, can OCT, being an in vivo biopsy of the optic nerve head, provide us with more information? And here we did a study, it's a long time ago actually, where we looked at the comparison with OCT with visual function and saw the bigger the drusen, the bigger the visual field defects. However, if you have sudden axonal damage due to optic disc drusen associated AION, the size of it didn't really matter. It's much more important whether it's deeply located or superficially located. So the deep drusen are much worse for the ischemic optic neuropathy. Final question, can AI help improving speed and accuracy? A long time ago, well, 8 years ago, we did manual segmentation of the drusen. It took like a day or something to segment one optic disc to get these nice images. Now we can do it using artificial intelligence together with our collaborator, Michael Girard, who's now in Atlanta, who has segmented the retinal layers. It took like 2 years to get this model using a lot of OCTs. And using this, we can now actually in milliseconds say whether there's no drusen or there's this blue structure here, which is the drusen. It was published last year in Neurology. And it's, of course, it's not commercialized yet, so we have to feed it with thousands of images before it can get commercialized, but it's very promising. We've also compared it with the visual field defect using the algorithms. It can also predict visual field effects. Okay, so take-home messages. OCT can be used to differentiate potentially sight and life-threatening disc edema from benign pseudoedema. It can provide us with more quantitative information regarding the structural damage, and AI can help us improving accuracy and speed. A software able to accurately and safely distinguish the two is probably coming, and AI, a rapid and accurate non-invasive ocular imaging-based biomarker for ICP estimation will thereby be possible. So I'd like to thank the Optic Distribution Studies Consortium, my AI collaborators, Michael Girard and Dan Milea, and my team and my funding bodies. Thank you very much.
Do you have time for questions? Shall we have like 1 or 2 questions now, and then we'll leave the rest to the end.
That was wonderful. I think you may have an OCT in your pocket, right? you. So my question is the number. You talked about OCT number, but what's your take on stability? Because a lot of literature says if it's stable, you can follow a pseudo. What do you think is pseudo, and if it's stable, is pseudo allowed to change more than 10 microns from visit to visit?
Well, good question. That depends very much on the age of the patient. So it's mostly relevant for kids, actually, because as I showed, there are a lot of pseudo-edema in kids.
Yes.
And here we see a very high degree of fluctuations in RNFL thickness from time to time. And it can fluctuate above 10 micrometers in kids.
That's my observation too,
Yeah.
but I have a hard time defending my argument, so now I can say
So
you agree that
yeah. We did a study and we have submitted
in
it.
children it's allowed.
Yeah,
and the number 2 is, do you get, sometimes I see a peripapillary circumlinear hemorrhage, a deep hemorrhage in what I think is drusen, and then I've got worried because I developed this, and I had the LP, and the LP in a child is opening pressure is normal. So have you seen that like a deep circumferential peripapillary?
Yes, we've seen that many times.
In pseudo?
In pseudo also, and we just follow them, and usually it resolves without any
So
secreting.
the hemorrhage type matters. If you see a streak hemorrhages, those are of course more concerning for true.
Yes.
Versus that. Okay,
Yes,
thank you
yes,
so much.
One other question. You didn't mention the upward deflection
Yeah,
of the membrane. What
yeah.
are your thoughts on that?
I think it's quite useful. There was a few, in interest of time, a few biomarkers that I didn't mention. This is one of them. I'm not using it that much, but it's not because it's not useful. I think it can be quite good also. Yeah.
So thank you very much. I think we'll hopefully have some time for questions at the end of our session, because in the interest of time, we have to welcome our next speaker, Dr. Anguo Wang from Taiwan, who's going to talk about treatment for LHON. Where are we now? So we have 2 genetics talks in a bit.
Good morning, everyone, and I would like to thank the organizing committee for inviting me here. And today I'm going to talk about treatment for lung disease. Where are we now? For the financial disclosure, I'm the principal investigator for reflex study. And we know that lung disease has been maternally inherited genetic disease reported by Dr. Theodor Lieber in 1871. And the treatment for the lung disease is mainly composed of two parts. The first one is the medical treatment using the idursulfase, which has been on the market since they have done the study in 2011. And the other part would be the gene therapy, which is to replace deficiency of 1177A mutation, and which is now in the phase 3 study. And we know that there's a RODO study that's 24 weeks, that's about half a year, a prospective randomized multi-control, multi-center study, and the inclusion criteria include lung disease with 3 primary mutations, and onset within 5 years. And they recruit 85 patients. The primary endpoint did not reach statistical significance. However, they found that patients with discordant visual acuity, all the secondary endpoints were significantly different in favor of idursulfase use. And later on, the Chiesi group take over the idursulfase, the Raxone, and so they conduct a LERO study, which is an open-label, international multi-center natural history control study. And in this study, they conduct with the same protocol of idursulfase, and however, they use it for 24 months, which is 2 years, and to be compared with an external natural history control group. And in this study, they confirmed the long-term efficacy of idursulfase in the subacute dynamic and also for the chronic patients. So in this picture, you can see that in the subacute, which is on your left-hand side, and for the chronic case, which is over 1 year, but within 5 years, the visual acuity improved in the treated eyes and worsened in the matched natural history group eyes, and which corresponds to a significant relative improvement of 6 and 5 letters in favor of idursulfase use, respectively, for the subacute dynamic and chronic group. However, in the subgroup analysis, they found an interesting finding that patients with 3460 mutation treatment significantly increased the proportion of eyes with a clinical relevant worsening. And you look at the map in more detail, you found that the spontaneous recovery rate is about 30% in the treatment group. However, it will increase to 60% for those cases in the natural history group with the 3460 mutation. So they proposed that maybe this worsening is caused by the spontaneous recovery may be overrepresented in the natural history cohort. And another theory they proposed would be that there's an NQO1 SMP which is responsible for the low NQO1 protein levels, which may hamper the reduction of idursulfase from its oxidized form. We know that the idursulfase, if that was still kept in the oxidized form, it would be cytotoxic to retinal ganglion cells. So in summary, for Raxone use, we will recommend lung patients with onset less than 5 years, and for the patients with 3460, we will explain the LERO's outcome before use. And for each patient, we suggest to treat 900 milligrams daily for at least 1 year. And if there's improvement, then we will continue for another 1 year after reaching plateau. And we will stop medication for patients who is intolerable to Raxone or visual improvement for 1 year. And next, we will talk about gene therapy. Gene therapy is adopting a strategy we call that allotopic expression, which we send the AAV carry the ND4 subunit into the retinal ganglion cell by endocytosis, and which will then be shuttled into the nucleus. And over there, the messenger RNA is transcribed. And this messenger RNA is tagged with a mitochondrial targeting signal. We call that MTS. And this MTS will carry the messenger RNA to the surface of the mitochondria. And over there, it was produced ND4 protein subunit and then incorporated into the mitochondria for the respiratory function. And we know that over the world, and there's 3 major groups who is doing the lung disease gene therapy. And on your left-hand side, that's the GeneSight Biologic, and it is a company based in Paris. It conduct multi-center study, and the vector they use is recombinant AAV2 with ND4 cDNA. We call that GS10, and it has been conduct phase 1/2 study and also 3 phase 3 study. The first 2 is called Rescue Reverse, and the recruitment has been completed in 2017, and the third one is called Reflect study, which the recruitment completed in 2019. And the second group in the middle is the Professor Zhang Gai, and who is the pioneer for developed the allotopic expression. However, they only conduct the phase 1/2 study. And the third group on your right-hand side is Professor Bing Li. He has been conducting investigator-initiated study in Tongji Hospital, Wuhan. And this group later on, they evolved into establish a company which called Neuro-Biotechnology Company, and it is based in Shanghai. And they have been using 2 vectors. One is NFS1, which is carrying ND4 subunit, especially for 11778 mutation. And the other one is NFS02, which is replacing ND1 cDNA. And this one is for the 3460 mutation. And both NFS1 and 2 have been conducting the phase 1/2 study in China, and the NFS1 has been recruiting patients for phase 3 study. So this would be the preliminary data provided by the Neuro-Biotechnology Company to me, and they found that for the phase 1/2 study, NFS1 has been very safe, and there is no severe AE and no dose-limiting toxicity for follow-up 1 year. And you can see that they have 2 groups. One is starting dose, and the other is high dose. The high dose seems to have a higher rate of response. So they think that this drug could be very beneficial for the patients. And for the phase 3 study, the recruitment has been completed in February 2023. And they said that the data should be coming out last year. And however, the data, we haven't seen the data. And I have contacted Professor Li Bing, and he told me the data will be released next year. And for the GeneSight study, the first 2 phase 3 trial, we call that Rescue and Reverse. The Rescue is recruiting patients with onset less than 6 months, and the Reverse recruiting patient onset between 6 to 12 months. And all the patients will receive GS10 intravitreal injection into the other eye, and the placebo in the contralateral eyes. And they found there's a clinically meaningful improvement of 25 and 28 ETDRS letters equivalent versus nadir in the GS10 treated eyes at about 2 years in Rescue and Reverse respectively. However, there's a bilateral improvement found after unilateral injection of GS10. So the primary endpoint to compare the visual outcome between the treated eye and the placebo eye does not meet statistic significance. So Reflect study is a double mask randomized GS10 versus placebo in second eye study. And they recruit patients with 11778 mutation with onset within 1 year and age over 15. And the vector they use is also GS10. The patient was randomized into 2 groups. The upper row is the study group. The first affected and second affected eye, these eyes will receive the GS10 injection. And for the control group, the first affected eye will receive GS10 injection. However, the contralateral second affected eye will receive placebo. So they recruit 98 patients with vision loss onset within 1 year, and the recruitment has been completed in 2019. And they report their data in the Brain Journal 2023, and on your right-hand side, you can see that the first affected eye have an improvement of 19 ETDRS letter, and the second affected eye in the study group have an improvement of 17 ETDRS letters. And for the lower row, you can see the control group, the EDTR, the first affected eye have an improvement of 17 EDTRS letters. And the placebo eye also have an improvement of 13 EDTRS letters. So in both the reflex reverse and reflex study, the primary endpoint was not met in all three phase 3 trials. And this is a small figure released by the company, but not published in the brand journal. And on your left-hand side, you can see the figure, and that's the average visual acuity. That's not the change of visual acuity, but the true visual acuity trace along the timeline. And the red line is the first affected eye. You can see over the treatment, there's a large improvement in the end. And the orange line is the second affected eye, which has also shown a moderate improvement. And the dark green line is the first affected eye in the control group, which showed a moderate improvement. And the light green line is the second affected eye in the control group, which shows a mild improvement. But the interesting part is that both eyes in each group will finally get to a similar final vision. And the study group show a better outcome than the control group. So it seems like it both have, not only have a bilateral effect, and also it shows a dose effect for this kind of gene therapy. And the GeneSight company also poured all the patients together from all phase 3 study. They put 107 results to an external group, control group of 208 matched patients from 11 natural history studies. And after adjustment of covariate, they found there is an estimated mean gain of 21 EDTRS letters versus natural history group in favor of gene therapy. And recently, the GeneSight company also performed a meta-analysis for the treatment outcome for the patient to compare the patients with 11778 mutation, and they have 3 groups of patients. The first group would be no treatment, that would be the natural history group. The second group would be the patient receiving idursulfase, and the third group would be the patient receiving the GS10 treatment. So they compared the clinical relevant recovery from nadir between these 3 groups. And they found that the clinical relevant recovery was about 17% in the non-treated group, 31% in the idursulfase treated group, and 59% in the gene therapy group. It seems that the gene therapy has the best visual outcome in this meta-analysis. So in summary, the recruitment of phase 3 clinical trial for NF01 has been completed in 2023, and the result will be released in 2026. And for the GeneSight company, all the phase 3 trials did not reach primary endpoint, and they are going to launch a new study called Recover at the end of this year. And as for the other potential treatment strategy, there's new technology. We call that mitochondrial target sequencing AAV virus, and which can help to directly deliver the wild-type mitochondrial DNA into the mitochondria. On the other hand, there is a gene editing tool. We call that DDCBE, and that would be a mitochondrial base editing system, which is CRISPR-free and RNA-free, and that can help to edit the gene for the mitochondrial mutation maybe in the future. Thank you for your attention.
Perhaps we will leave all the questions till the end, because
Okay,
I think
thank
in fact, it's great that we also have Dr. Patrick Yuiman, who in fact is very involved in research into hereditary optic neuropathies. He's going to tell us about therapeutic approaches for dominant optic atrophy, and I'm sure in the Q&A session which follows, he can also answer questions along with Dr. Wang on LHON treatment as well.
Thank you very much, Professor Chan. Thank you very much to the organizers for the opportunity to take part in this session. And it's a good way of moving on to one of the other big topics in terms of inherited optic neuropathies and gene therapy. I'm going to be talking on dominant optic atrophy. These are my financial disclosures. I don't have any stocks and shares in any of the companies mentioned in this talk. Autosomal dominant optic atrophy is the most common inherited optic neuropathy in the general population. The prevalence in the United Kingdom is about 1 in 25,000. You get progressive loss of vision from early childhood, and there is this very peculiar problem where you have the genetic defect in every cell in the human body, but for some reasons you get this preferential involvement of the retinal ganglion cells, especially those located within the papillomacular bundle. It is a heterogeneous condition in terms of the genetic defect, but about 60 to 70% of patients will carry pathogenic variants in the nuclear encoded gene OPA1, which is located on chromosome 3. If you go back to your medical textbook, these mitochondria do not exist as little jelly beans floating around the cell, but it actually exists as a highly interconnected network with constant fusion and fission. Some of you will be seeing patients with mitofusin 2 genetic defects in your clinic, but mitofusin 2 is involved in outer membrane fusion, whereas OPA1 is involved in inner membrane fusion. So these are two very important pro-fusion proteins. So what does the OPA1 protein does? It is a mitochondrial inner membrane protein. It is involved with a number of biological functions which all contribute to normal mitochondrial function. And if for whatever reason you have a defect in the OPA1 gene, you end up with a defective OPA1 protein or not enough OPA1 protein, and you get a decrease in the amount of ATP being produced. And then the other downstream effect is that you have increased levels of these reactive oxygen species. So compare with Leber's optic neuropathy, which is a mitochondrial primary disease. Dominant optic atrophy caused by OPA1 is a nuclear encoded mitochondrial optic neuropathy. So this is quite a nice example of both. So what about treatment for this condition, which I'm going to focus on OPA1 simply because I don't have time. Let's talk about neuroprotective drugs. We already heard from Professor Wang from Taipei that idebenone is a synthetic ubiquinone analog, and it's quite a neat protein in terms of what it does, because it pushes electrons along the mitochondrial inner membrane, and because of this you get an increase in the amount of ATP being produced, and you get decreased level of these reactive oxygen species, and that's the reason why this has been used for Leber's optic neuropathy. You've heard already about the latest study, the LEROS study that was published earlier last year, and this was quite a neat study because it showed in a large cohort of patients, nearly 200, that idebenone was effective not only in the acute stage but also in the chronic stage of the disease, and that's the reason why we provide this now to patients with this condition. What about idebenone in the context of a different mitochondrial optic neuropathy? It makes sense if it's working for Leber's optic neuropathy. In theory, this should help with other forms of mitochondrial cytopathy. And there have been a number of case series which were mostly retrospective and of course does not reach the level of evidence that you get with a randomized controlled trial. Having said that, there is some good data that idebenone can stabilize or even improve vision in a subgroup of treated patients. Now, what do we do with that kind of data? Obviously, patients will read about this. Some of my patients will come to me saying whether or not they should be taking idebenone. The bottom line is that we don't have level A evidence, and some of them decide to take idebenone, but that's very much on their own choice. What we need is a properly randomized controlled trial, which is adequately controlled, and we're in discussion with the company to try and move this forward. What about innovative therapies? I think the challenges of rare disease is that we don't have effective treatment, but the exciting for us researchers is that it provides us with a lot of potential areas where we can translate things coming from the lab. As I mentioned already, there are a number of genetic mutations. Most of these will result in haploinsufficiency. So what do I mean by haploinsufficiency? This means that you get a decrease in the amount of wild-type protein. So in theory, if you're able to increase the level of the wild-type protein, you could rescue these retinal ganglion cells and stabilize vision, and even in some circumstances improve vision. We work very closely with a very good team in Angers, France. Guy Lenaire is the head of the unit there. And I'm going to talk very briefly about a strategy called mRNA transplicing. It's actually not very complicated. So if you look at this graphic here, this is the OPA1 protein with all, not the protein, but the DNA with all the exons. DNA gets converted into mRNA, and then after the mRNA is produced, again going back to your early preclinical days, you have to splice and remove all the excessive material there to produce a smaller mRNA species. If you have a mutation, and most of these mutations are located towards the tail end of the exonic material, you end up with mutated OP1 mRNA, and most of these mutated mRNA gets degraded. Because it gets degraded, you don't produce enough protein. But what you do with transplicing is you produce and you provide an alternative mRNA species, the therapeutic mRNA, and then you basically transplice, and you end up with a wild-type version which produces the protein. So this is effectively a genomic cut and paste, and you increase the level of the wild-type OPA1. Does it work? So these are studies which have been done in human fibroblasts, and essentially when you do the transplicing, you get a very nice increased level of the OP1 protein. And when you increase the level of the OP1 protein, you're able to rescue mitochondrial fragmentation. So you can see here that when you introduce the therapeutic transplicing strategy, rather than having fragmented mitochondria, you have mitochondria which are of the right length. So we're now testing this in human iPSC models, and perhaps with some luck we can move on to early phase clinical trials. The other way that you can increase the amount of wild-type protein is the use of these so-called antisense oligonucleotides. Some of you will be aware of what ASOs are. But again, this is a form of mRNA therapeutic. This is not DNA gene therapy, this is mRNA therapeutics, where you're trying to improve the amount of functional protein. So how does it work, right? So as I mentioned already, you produce mRNA, but you do not get a complete conversion of all RNAs into protein. So there is a degree of redundancy, there is a degree of inefficiency. So what you can do with using these antisense oligonucleotides is that you can modify these RNAs and push them towards being converted into protein. So this is at a slightly more advanced phase. So essentially there are two companies working on this, Stoke Therapeutics and PYC Therapeutics, and they are now both moving to phase 1 clinical trials. So what about induced pluripotent stem cells? Because all your patients will come to your clinic saying, well, doctor, I've read about stem cell, I want to have my stem cell injection. Well, hang on here, we're not there yet, right? So this is a collaboration. I'm also based at Moorfields, and we do some research at the Institute of Ophthalmology. This work is led by Mike Cheetham, who's a professor of molecular cell biology, and the other people there are members of the junior team. So to cut a long story short, we basically converted a group of OPA1 patient-derived fibroblasts into these iPSCs, and then by using a very elegant and time-consuming protocol, you can convert these iPSCs into retinal ganglion cells. So rather than correcting the problem later on down the line, can we actually correct the underlying genetic defect to try and prevent disease from progressing? As a proof of principle, we carried out this study where we used CRISPR-Cas9 to correct the underlying genetic defect. And you can see here that in patients with an OP1 mutation, you get a reduction in the amount of ATP being produced, which is not a big surprise. By correcting the genetic defect using this CRISPR technology, you're able to increase the level of ATP being produced, which is, again, a very nice outcome. Not only this, you're rescuing the bioenergetic defect, but you can also see here that you get a fragmented mitochondria, and by correcting the underlying genetic defect, you're able to rescue the mitochondrial network fragmentation. So I think, hopefully I've convinced you that from bench to bedside, we're now hopefully moving towards a phase where we can translate some of these preclinical studies. There is some data based on retrospective smaller case series that identified as in Leber's optic neuropathy could help stabilize or even improve vision in a subgroup of treated patients. mRNA expression is being used in a wide range of neurodegenerative diseases. There is good preclinical data that we can actually modify and modulate mRNA expression using either mRNA transplicing or antisense oligonucleotides. Of course, the main thing about early phase 1 clinical trials is that we need to be sure about safety, because these will need to be delivered intravitreally. But if safety is confirmed, then we can move on into more definitive phase 2, phase 3 to look at efficacy. OPA1 gene editing is obviously something that we need to think of because it could correct the root cause of the problem. As always, these are early days. We're only doing this in vitro cell models. We need to be very careful with our patients not to give them unexpected high hope that this will happen in the next few years. I think this is more in terms of the 5 to 10 year time frame. So obviously the work I'm presenting here is not the work of one person or one group. I'm very fortunate to work with a very talented group of people both in Cambridge and in London, also with a wide international network of friends across the world, and very happy to answer any questions you might have later on in the Q&A session.
Thank you very much, Patrick. That was fascinating. We'll keep the questions at the end of the session so that we can run through all the talks first. Next, we have Dr. Sangeeta Khanna. She's going to talk about IH update on treatment. Dr. Sangeeta has been a regular speaker at INOS and AIOS meetings. Welcome.
Thank you to the organizers for the invite. And I have no disclosures. Just reviewing IIH, how do we diagnose? Presence of papilledema is a requirement. And then there should be absence of other neurologic focal deficits other than cranial nerve 6 is allowed. Should be awake and alert patient with normal neuroimaging. And of course, there are signs of IIH, which we'll see in the next slide, which are allowed. And the opening pressure should be more than 25 centimeters of water, and in children more than 28, but more importantly, a normal CSF constituents, and basically excluding other causes of raised ICP. So the radiologic features of IIH include deformity of the globe or globe flattening, as you can see here in this slide. I don't have a mouse, so that's okay. I don't think there's a mouse. Is there? Oh, okay. So you see the flattening of the globe here, and flattening in the literature is said to be specific for papilledema. And distension of the optic nerve sheets or tortuous sheets, which you may see as more CSF, which is in the white around the optic nerves. That's a hard one to call by the radiologist as well. The empty sella is frequently seen in patients, but also seen in controls. Then there is venous sinus stenosis, which is actually seen in a high proportion of patients with IIH and is quite specific, not seen in controls. The prevalence in a study that they looked at the prevalence of papilledema and these signs, they saw that in patients who had at least one MRI sign, of IIH, the prevalence was 2% or so, and that was 40% if there were 4 signs present. So combination is more suggestive of IIH. So once you've diagnosed IIH, you want to look at management. The management, why do we treat? It's primarily directed towards prevention of vision loss. And of course, there are other symptoms such as intractable headaches, or some patients are bothered by pulsatile tinnitus. But we as ophthalmologists really worry about preventing vision loss. And vision loss in IIH has this kind of a progression. It starts with peripheral visual deficits and increases towards the central field, just like glaucoma, but faster. And central vision is affected late in the course of disease. Therefore, perimetry is very important in monitoring disease, and one measure that has been used in literature is the mean deviation. This mean deviation is averaging all the spots, the threshold sensitivity reduction at each spot tested, but is also weighted for the central points. And so that's a number you would see being used in studies subsequently.
Ganglion cell loss on OCT can also be used as a marker of vision loss because that's not affected by nerve head edema and has micron scale resolution. So the first study that we've had for the use of acetazolamide was the IIH-TT, the IIH treatment trial. It's the first prospective multicenter double-blind placebo-controlled study to evaluate the treatment strategies. Remember that the inclusion criteria, this was limited to patients with mild visual field defects. So the mean deviation was less than -7 decibel. And what they showed was they started patients on 500 BID acetazolamide, and this was increased to 4 grams per day. And what they showed, as you can see in the x-axis has the months from onset of treatment, and the y-axis has the mean change in that perimetric mean deviation, which is how the visual field improved. Within a month, the acetazolamide group is doing better than the placebo group. So what they showed was that acetazolamide plus low sodium diet led to improved visual outcomes, and also that acetazolamide is safe and tolerable at doses up to 4 grams a day for IIH if tolerated. And also patients had improved quality of life, particularly in improvement of vision, the tinnitus, but remember that headaches did not show a difference in the two groups. So if the patients still have headache, doesn't mean their IIH is not controlled. So they often need a multi-pronged approach to headache management. So the medical management of IIH works for this, can work very well, but it may not be enough when patients are presenting with rapidly worsening vision loss or they are refractory to medical management alone. And if you look at all cases, about 10% are refractory to medical treatment alone, and 2.9% can present with fulminant vision loss. So what are our options there? There is the CSF diversion procedure, or stereotactic VP shunt as a preferred diversion procedure. Optic nerve sheath fenestration, which is used primarily for patients who present with threatened vision. And the third option is venous sinus stenting. Now, there is no head-to-head comparison. There's no randomized controlled trial for this, but there is a case series, and there's a systematic review of surgical treatments. And if you see the first column here, all the three measures did pretty well in improving vision or stabilizing, improving and stabilizing. The small proportion of patients improve, more get stabilized, or improving papilledema. However, venous sinus stent also addressed more headaches and the symptoms were better. Failure rate, the shunts have more failure rate than other procedures. And in ONSF, of course, they had to continue medical treatment in addition to the ONSF. And severe complication rates were similar in ONSF and venous sinus stent. So let's look at venous sinus stenting. What is venous sinus stenting? So these are the venous sinuses in our brain. And the superior sagittal sinus meets the, let me see. Okay, here. So this is the transverse sinus and the sigmoid sinus junction. This is where you will see the stenosis developing. And so stenosis at the transverse sigmoid junction is seen in almost 93% of patients with IIH. And the degree of stenosis, however, does not correlate with clinical course, degree of vision loss, or even opening pressure. And it has been shown that the stenosis can actually be reversible following high volume CSF drainage. It's almost like a vicious cycle there, that the venous sinus stenosis can be caused by high pressure, but then it aggravates the high pressure. So it's a positive feedback. And which is the chicken or the egg question comes up. But what we do know is that the venous sinus stenting does help. This was the one prospective trial that addressed 13 patients with IIH who were either medically refractory or presented with fulminant IIH, and they had a favorable transstenotic gradient. They underwent unilateral venous sinus stenting, and the opening pressure improved from 42 mean pressure to 22 post-stent. And this decrease happens pretty quickly. And their mean deviation on the visual field improved in 80% and papilledema in 85% at 3-month follow-up visit. Patient-reported outcomes also improved in transient visual obscurations, diplopia, tinnitus, headache, and the only thing was some had persistent headaches. And those with fulminant vision loss also showed, 3 out of 13 showed improvement, and none developed atrophy, so they did stabilize. So besides this prospective study, there is another retrospective study which showed that that was combining all patients in Stanford and Mayo Clinic, and they showed that 1/3 of patients could stop medication right away, and almost every patient had reduction in papilledema and improvement in visual field. So suddenly we have efficacy. But the elephant in the room is complications, right? So you're putting a stent in the cerebral venous sinus. So in this prospective study, they only had no serious adverse events. They had one small self-limited retroperitoneal hemorrhage because of the angiogram and the catheter that is entered at the groin, the transient head or pelvic pain, and one allergic reaction to contrast. So in that's the prospective. But if you look at the meta-analysis of 1,626 patients who underwent venous sinus stenting for IIH, stent thrombosis, in-stent stenosis, stent adjacent stenosis, transverse sinus thrombosis, and subdural hematoma, these were somewhere in the range of 1% or less. And the neurointerventionist or the neurosurgeon, whoever does a procedure, they are really cognizant of not getting stent thrombosis, and we'll talk about that. So let's go to a case. This is a 36-year-old female with 3 weeks of transient visual obscurations and headaches. She has reduced some reduction in visual field, and she gets an MR brain and MR venogram, and there is no venous sinus thrombosis, but there's bilateral venous sinus stenosis. Opening pressure is elevated. So this is a candidate just for medical treatment. Certainly we'll try that. She was started on acetazolamide, but could not tolerate, had worsening symptoms, and at that point, being refractory to the treatment, and the neurointerventionist was consulted for consideration of stent. So next step is they do a cerebral angiogram. They measure the stenosis gradient, and though it's not too high, it's higher than 8. The 8 is what they use as cutoff, and then though even if it's present in both sides, they'll stent only the dominant sinus. And she went urgent stenting, and they measure the post-stenting gradients is reduced to 4. And this is the stent. If you can see, it's placed in that area. And you can see how the stenosis has opened up. And the 2 stents that are commonly used in our setting is the Cordis Precise and Zilver. And both are not really designed for the venous sinuses. They are used in other vascular procedures, but can be used for venous sinuses. Follow-up 2 months post-stent, she has resolved papilledema. She could come off the medication. Her visual field has improved. So what is the process of venous sinus stenting? You first diagnose IIH using the Dandy criteria. You have to demonstrate indication for stent placement, so you do a MRV or CTV. There has to be evidence of venous sinus stenosis. Then they undergo formal angiogram confirming stenosis, And once they also measure the gradient more than 8 millimeter, and then the stent is placed. But after that, prior to stent, there is 2 to 5 days of dual antiplatelet therapy to prevent stent thrombosis, and they are continued on that for 1 to 3 months, and aspirin for 1 year. So what is the indication? Just summarizing, select patients with vision-threatening papilledema who present with rapidly worsening vision loss, that is the fulminant IIH, and venous sinus stenosis with favorable gradient, or chronic refractory papilledema. Who are poor candidates for venous sinus stent? Patients without the venous pressure gradients or high risk for stent thrombosis. They have prothrombotic disorders, or they have severe coagulopathy or bleeding disorders. They cannot be on dual antiplatelets, or previously failed stenting with restenosis, or those who cannot be compliant or have a high fall risk, and they cannot be put on a dual antiplatelet therapy. Or if they have metal allergies, they cannot tolerate that stent. So mid and long-term outcomes are coming out, but they're still limited to a few years. And what they found that most patients do well with this, more than 90% of improvement in papilledema, and the headache recurrence, however, remains common, though return of papilledema, need for additional surgical intervention, or recurrent increase in ICP remains uncommon. Thank you.
Thank you, Professor Khan. It was an excellent update on IIH. And personally, I rarely see patients with IIH in Japan, but it's very informative, and I really impressed. We have the next speaker. Please come out, Professor Ambika. It's my great pleasure to introduce you to the next speaker, Professor Ambika. And she is very well known by her work on clinical and basic research on optic neuritis. And so it's very exciting for me to what kind of talk she's going to say. Go ahead.
Thank you, Dr. Kashi, for this warm introduction. Good morning, everyone. I'm going to talk on current concepts of MOG optic neuritis. I wish I could say that I have a financial disclosure, but no. So we are all very aware that ever since the discovery of these seromarkers have come into the literature, management of optic neuritis is having more clarity, and I'm going to discuss the MOG optic neuritis in this particular talk. And this seromarker positivity and MOG antibody characterization is very clear about the demographic nature, optic nerve characters, and the imaging aspects of MOG optic neuritis. So MOG optic neuritis can be a spectrum of disease. It can be an isolated optic neuritis or a myelitis, multifocal CNS demyelination, or ADEM, which is more commonly seen in pediatric age group. And the MOG optic neuritis can be bilateral, recurrent, with severe disc edema, with a perineural enhancement on MRI, and it can affect any age group, and mostly it is in the third decade, and men and women are equally involved, and the presence of severe vision loss, which usually responds well, unlike the NMO spectrum disorders, is characteristic of a MOG. But as the relapses increases, we have to be cautious because we may not get the same type of recovery. And coming to the imaging characters, we can see this type of, I think the cursor, yep, there it is. So you can see this type of anterior long signals along the optic nerve, which have a characteristic perineural enhancement that is typical for an optic neuritis, and they very seldom engage the chiasm and the posterior aspect of the optic nerve. And these are the fluffy brain lesions, which can be hyperintense and mostly less than 3 millimeter, and they don't occupy the areas like Dawson's fingers areas, S and U type of lesion. They usually involve the thalamic, pontine, and cerebellar peduncle regions. And the MRI spine will show the classical head sign, and sometimes we can also see a long segment involving lesions in a MOG2. And serum MOG antibody testing, ideal is to do a live cell-based assay, which is a characteristic pattern of assessment, but we also have fixed cell-based assays which are available. And false positivity is quite common when we use a low dilution, and high titers can cause a relapsing event of optic neuritis, and sometimes negative report is equalizing to a disease recovery. And persisting high titers, as I mentioned, is a poor prognostic factor, and it also predicts the relapses of the patient, which can happen down the line when you are going to taper down the medications. And the positive predictive value of a mock testing will definitely vary depending on the epidemiological background to certain extent. And ever since Brenda et al. Had come up with this diagnostic criteria for MOGED, it is quite clear what type of optic neuritis we are going to brand as a MOGED spectrum of optic neuritis. And regarding the timing of the mock testing in this particular study has said that although we follow this three-step approach of having the core clinical and the supportive evidence and a positive cell-based assay mock titers, sometimes we may have a clinical and a radiological features suggestive of a MOGED, but the titers may be low. So in spite of that, we do make a diagnosis of MOGED, because 25% of the patients can become low positive by 6 months, and by 1 year, 50% of them will totally be seronegative after the disease onset. So the clear high titer positivity, particularly in the IgG1, is considered within 1 month of the onset of the clinical features, is considered to be very pathognomonic of a MOGED. And pre-treatment steroids, this study showed that did not significantly affect the MOG results. And this particular study has shown the conversion of from laboratory to the real world experience of the IgG positivity of MOGED. They said that the low MOG positivity has definitely have some diagnostic implications, which mean a patient, this study involved the cell-based fixed assay, the Euroimmune kit. And they showed that the MOGED criteria was met only by 35% of the 35 patients among the low strength positives in this group, whereas if there are high strength positives, most of them had a MOGED diagnostic criteria to be positive. And this study diagnosed the various CSF markers in NMO and MOGED and tried to imply their clinical use. These CSF samples were analyzed for GFAP, the albumin quotient, and all this other other markers, and they found that MOGED patients had high CSF lymphocyte counts with elevated lymphocyte counts, particularly correlating with a polyphasic event. MOGED can be even a multiple relapsing events, unlike the children where they will have more of ADEM presentation. So the antibody profiling of these regarding the MOGED, NMO, and the double seronegative, these groups they also used to predict the seromarkers for the recovery of the optic neuritis. Of the 47 patients, what they included, they found that the MOG status was associated with a higher quality of visual improvement, unlike the NMO spectrum disorders. And severe visual disability, they concluded that it's very less frequent in MOG spectrum disease, unlike NMO spectrum. And this is the new thing which is being discussed in the literature, MOG patients showing a raised CSF pressure. This is also being reported in the study that of the 28 MOGED cases, almost many of them had 26 to 46 centimeters of CSF pressure when they tried to tap. So this has to be kept in mind, particularly when the patient is going to come with optic neuritis and features of meningoencephalitis, because that is the time when the CSF pressure has been recorded to be high in this group of patients. So coming to the treatment of demyelinating optic neuritis, yes, all of them will require an acute treatment and a chronic treatment. If it is going to be an acute treatment, it is invariably intravenous steroid, and if it is a chronic treatment, we need a long-term maintenance immunosuppression. And this is a nice algorithm which is given in one of the neurology articles, where they said that after that acute event, if the diagnosis of MOGED is confirmed, go ahead with the IV steroid and plex them if they are going to be as early as possible. Earlier it was described more for NMO, but now even plex is being a choice for MOGED patients if they are going to have no recovery by 1 week or so. And the preventive maintenance therapy can be depending on the persistent MOG titers. If the MOG titers are quite high, then better to keep them on a chronic immunosuppression, which can range from oral prednisolone to oral immunosuppression, or a pulsed IV IG cycles, or even a monoclonal antibodies. Because this is the group of disease which, when you come down on steroids, the patient will boomerang back with a relapsed attack of neuritis. So we have to keep such patients for a chronic immunosuppression. And as I have discussed on this, this is a nice article where John et al. Had compared all the possible options for plasma exchange of all optic neuritis, and they also conclude that MOG disease optic neuritis within a month has a better choice for plex therapy, and older age, delayed treatment and poor vision at onset will be poor response predictors. And these are other types of immunosuppression which are involved in MOGET, where IVIG and MyCept had a reduced ARR rate. And this is another studies which compared use of rituximab in MOGED versus NMO, and they found that rituximab had a better control of NMO spectrum disorders rather than a MOGED, but IVIG is one option which can also reduce the relapse rate in MOGED. And there are a lot of IL-6 inhibitors also which are being used, but I think our part of the world, it is not so much in practice. And this is a study which has come up, which is an open label single arm study in the literature, where they have tried tocilizumab for patients who are refractile for MOG spectrum disorders, and particularly for the optic neuritis. And they found that the relapse rate was significantly low in 7 of their patients when they had given options of tocilizumab. So there are options of optic neuritis beyond MOG also in this part of the world. Elderly age group, painless or painful vision loss, severe disc edema with lot of hemorrhages and cottonwool spots, progression of visual loss beyond 2 weeks, poor response to treatment, severe recurrences with steroid dependence, and a lot of autoimmune diseases can be along attached with these group of disease, starting from SLE to GPA to IgG4, Behçet's or sarcoid. We have to be very cautious. So we do an extensive blood workup when we are going to plan for this type of chronic immunosuppression therapy for all this group of patients. And these are the lists what we routinely practice in our setup. I'm going to show one case example where a 66-year-old female came with a complaint of sudden painful vision drop in the right eye over a period of 3 days. And she was diabetic and hypertensive. There were no signs of giant cell arteritis or raised ICP, and she did not have any other systemic illness. And her visual acuity in the right eye was almost counting fingers closed face, and that of the left eye parameters were normal. You could see that a very subtle disc edema with a splinter hemorrhage, and the vision was counting fingers closed face at 60+ age group. Now I revisit my diagnosis of all the ischemic optic neuritis what I have made in the past. So because after this MOG, we are very skeptical in making this type of diagnosis. So this is the imaging character where you can see a long sheath enhancing signal along the right side, and that is a diffuse thickening of the T2 with an enhancement of the right, which you can see as a classical perineuritis. So the patient also had few hyperintense signals in the deep cortical matter, but they were mostly small vessel ischemic changes. So we did our routine labs for her, and most of them were negative, and she was negative for all the autoimmune granulomatous and all the spectrum disorders, but these two came positive. So she's got a HRCT having nodes, she's positive for MOG, she's positive for quantiferon. So now what do I do? So we involved an infectious disease consultant and a neurologist. We went ahead for a CSF. The pressure was normal, the analysis was normal. Her gene expert CSF was negative as usual. So she was treated with intravenous steroids and tapering steroids along with a course of antitubercular treatment. So we don't have a choice. When we have these two positive in a 60+, and I'm going to keep her, if she's going to come back with the relapse, I don't have a choice, I have to escalate my immunosuppression for her. So post-treatment, she did recover from counting fingers to almost 618 by 2 weeks, and she recovered by 3 months to 6/9, and she's still on antituberculous treatment. So in our part of the world, when we are going to consider for a chronic immunosuppression, always do rule out all the spectrum of infectious diseases, because that's going to give us a lot of problem than the immunosuppression per se. And in the literature also, there are a lot of differences And this is an article which compared white versus Asian race MOGAD spectrum, and they found that non-Asian population had more recurrent, painful, and bilateral involvement. And the vision outcome and clinical features were almost similar, but MOGAD most of the time had a limited optic neuritis in Asians. And we tried to analyze our population in our center, and we tried to do all the optic neuritis with and without seromarkers. We compared their clinical behavior, and this was a retrospective data of 203 patients, and we excluded all other causes of optic neuritis, optic neuropathies, and we found that we had most of our MOG optic neuritis presenting with a disc edema, and that of the analysis, most of them had a seronegative. So double negative was high in our group of people, followed by the MOG optic neuritis, and then the NMO, and MS was very less in our part of the optic neuritis patients. So to conclude, MOGAD diagnosis is very clear, and the diagnostic criteria in 2023 has helped us and refined the management of MOGAD. Acute treatment will involve intravenous steroid followed by a slow, long oral taper of steroids. And EDEM is very common in children, but optic neuritis is common in adults. And clinical and imaging features will request for a MOG antibody testing. And we always nowadays we do, even with the first attack, we are doing all the seromarkers, because the access for these seromarker analysis is not available throughout India in all the places. Poor recovery and higher relapses and consistently high MOG titer will warrant a long-term immunosuppression. It's always better to rule out other infective etiologies before putting these patients on chronic immunosuppression, and probably we need a lot of prospective RCTs to find out how long we continue this immunosuppression in these patients and when to stop. Thank you so much.
Well, that was an excellent talk. Thank you, Professor Ambika. The discussions will be done after this, the next talk. I'm really happy to introduce you, Professor Carl Golniak. Somehow we have been involved in ICO things. He's working on the educational committee, and somehow I was involved in WHO ICD classification things. And both of us are working on outside of the realm of the neuro-ophthalmology. But now he's going to talk on immunosuppressants and for neuro-ophthalmology.
Well, thank you. It's a pleasure to be here. Unlike our first speaker, who got to talk about his favorite topic, this is not my favorite topic. New immunosuppressants in neuro-ophthalmology. And my objectives are that, and I knew is a relative term, so I chose 2017 as my cutoff, and there is just an explosion of these immunosuppressants. So there's no way I can cover all of these things in a short talk, which I'll save some time hopefully for you too. So I decided to pick 2017 and these conditions: myasthenia, MSNMO, and MOGAD, which on Ambika just made my job easier on the MOGAD side, and then thyroid eye disease. I have no relevant financial interest in any of these things. So myasthenia, there are a couple of classes of drugs, and I think for me, I have to look these things up, and I think they also were trying to see if they could tongue-tie me with all the names of all these different medications. So eculizumab, ravulizumab, and zilucoplan are three of the newer drugs that inhibit complement 5 cleavage. And I'm trying to depict in this diagram. I'll try not to torture you with the immune system cascades as much as I can. The first two are IV. The second is very new. It's sub-Q. And all the medications I'm talking about are FDA approved in the United States, which means they've all undergone extensive testing. So I limit it also to FDA approved drugs. So what happens is it inhibits this cleavage, which then stops the cascade of complement activation and all of the immune products. And that's how they work. The second type class of drugs used for myasthenia are the efgartigimod, rozanolixizumab, which both block neonatal FC receptor. So in the bottom left diagram, what happens is these FC receptors bind to immunoglobulins and allows it to get into the cell where it can't be degraded by extracellular mechanisms. So if you block these receptors, then you block getting the immunoglobulin into the cell, and it can be more easily degraded. So it decreases the IgG and inflammation. For MS, there are many, many drugs available that have been approved. I show you this list not for you to really read all of it, but just to show you there's a lot of medicines. Some of these are decades old, and so again, I'm going to concentrate on some of the newer ones that have been approved, and again, two sort of main classes. They're the ocrelizumab, ublituximab, and ofatumumab, which both target the CD20 receptor or the CD20 molecule on B cells. And what happens then is when it targets the CD20, it starts a cascade of complement and cell-mediated B cell death, which leads to decreased immunoglobulins and decreased inflammation. These are all intravenous. And the other class are the sphingosine-1 phosphate receptor binders, siponimod and ponesimod, and this reduces migration of lymphocytes into the CNS. So you see here where that yellow arrow is, you have some sort of inciting immune trigger. The immune cells accumulate, and typically they will bind to the sphingosine-1 phosphate receptor, and that allows them to get into the central nervous system. So if you can block that sphingosine-1 phosphate receptor with these medicines, it prevents the immunoglobulins, or the lymphocytes getting into the central nervous system. And that's how this class of drugs works. And these we've already talked about, this type of drugs that inhibits the cleavage of complement 5. So eculizumab and ravulizumab have both been approved for the treatment. Now we're talking about NMO, not MS, NMO, have been approved and work in the same way we talked about with myasthenia. There are a couple of other drugs that have been approved. This one, inebilizumab, which targets CD19 on B cells with the same sort of effect that the ones that target CD20. It causes this complement and immune effector cells to kill B cells and decrease the immunoglobulins. The other drug that's been approved is satralizumab, which Ambika mentioned. This targets the interleukin-6 receptor. So on the left side of the figure, you can see that what happens, the interleukin-6 binds this GP130 protein, and then that starts this JAK cascade, the JAK cascade of inflammatory reactants. So if you can bind the IL-6 receptor and prevent it from binding to the GP130, you can stop the JAK cascade. And so this is another class of drugs. And of course, there are many different drugs that do the same thing that are under development because it's lucrative. So that's the area of it. And then MOGAD, really, there are no FDA-approved drugs for long-term treatment. And all the drugs I just mentioned, if it's not obvious for MS and MO, are not the acute treatment. Those are the long-term treatment to prevent optic neuritis and all the other things that can happen with these conditions. The treatment for MOGAD is, as Dr. Ambika said, high-dose steroids without rapid recovery, either plasma exchange or intravenous immunoglobulin. We have no FDA-approved long-term treatments, but there are medicines that are used under the circumstances that she described, which I will not describe again. And then the final disease, thyroid eye disease, teprotumumab or Tepeza is approved by the FDA. It's actually, I was just at the Emirates Society of Ophthalmology meeting last month, or the month before, and they're now marketing it in the Middle East. I don't think they're marketing elsewhere quite yet, but it's an insulin-like growth factor 1 inhibitor, which decreases inflammation and tissue growth. It's an intravenous infusion, 10 milligrams per kilogram the first dose, and then 20 milligrams per kilogram every 3 weeks for a total of 8 total injections. And this is a figure from the paper with a QR code here, and you can see the baseline prior to the teprotumumab, and then at 24 weeks after the initial dose was given, the marked improvement, at least in this case. These graphs, probably hard to read. The upper left is response in proptosis. The middle left is clinical activity score. The bottom left, double vision response. Change from baseline in proptosis, overall response. So the dark black line is the teprotumumab, and the lightly shaded line. And there were all of these things were highly statistically significantly better for thyroid patients on this medication. There is a catch to all of these medications. I don't have the data on how much all of the medications cost, but I do for this one. So it's $15,000 for a vial, but depending on how much you weigh, it's going to be in the $120,000 to $225,000 for a 24-week for the entire course. I can tell you that I've used this some number of times. Our patients, at least, nobody pays $225,000. Somebody pays, insurance pays, which means probably all of us that live in the United States pay, but it's not, in my opinion, financially sustainable. And I would say, although I have been in the past a consultant, not currently, for the company that makes this, I'm not that impressed with the results. So in summary, new immunosuppressants are changing how we treat several common neuro-ophthalmic conditions. They work by either blocking complement cascade, the JAK system, decreasing IgG by B-cell destruction, or preventing IgG by getting into the central nervous system. And I thank you for your attention.
Thank you, Dr. Golnick, and all the speakers. Well, now we have some question time. So do we have any pressing questions from anyone? Yes. Maybe that gentleman from the back. Oh, by the way.
Use of protein mRNA in optic nerve atrophy.
Right, yes. Sorry, what was the question?
In optic nerve atrophy due to glaucoma.
Oh, yes, right. So I guess mRNA therapeutics is actually a hot topic, right? The slight difficulty with glaucoma is you're dealing with a multifactorial disease, right? Both in terms of whether or not it's an IOP-driven pathology, or whether, is it working? Right.
Yes, it is.
Or whether it is essentially you want to modulate some form of neuroprotection, but certainly you could use mRNA therapeutics to modulate neuroprotective factors with the aim of protecting the retinal ganglion cells, right? So this is also something that can be used for other optic neuropathies.
Okay.
I have a question for Patrick too. We know that transplicing have a 5' and 3', and as we know that OPA1 mutation have so many mutations along the 28 exons along the OPA1 gene. And what would be the better strategy to package the 5' and 3' together in one AAV, or solve them each by one?
Yes, right. So this is a very good question from Professor Wang, and essentially there are a lot of difficulties when it comes to OPA1. Number one is there are more than 500 pathogenic variants that have been reported, right? Two main disease mechanisms, haploinsufficiency in probably about 2/3 of cases, and dominant negative effects in 1/3, which is more tricky. Third difficulty is that OPA1 exists as 8 isoforms, right? So all these isoforms vary depending on which cell you're dealing with, right? So if you're going to be dealing with strategy, right, you will have to deal with one where potentially you're able to restore the actual balance that you need in these retinal ganglion cells, right? So that's the reason why I think, for example, strategies involving mRNA transplicing are better, because it overcomes these challenges with traditional gene replacement therapy, right? And the other difficulty is that you need to be very sure that you don't have overexpression of the OPA1, because overexpression can also be detrimental. So let's assume you need 100% of your wild-type protein, right? And in most of these mutations, you get 50% reduction, let's put it like this, right? So if you go in, all guns blazing, and you're basically trying to use an AAV2 strategy, and you increase it to supraphysiological levels, then you could actually result in mitochondrial fragmentation, right? So compared with Leber's optic neuropathy, I think there are different challenges, and I suspect what will happen in the long term is that you will have more targeted treatment depending on which mutation, haploinsufficient versus dominant negative, and then it's easy for me to say this, but this means it will improve the challenges in terms of the cost and the time it will take for us to do this.
and pseudodyskedema, optic nerve drusen. I would like to ask you whether a B scan is more sensitive, because almost, it's very difficult for novice people to differentiate between a true and a pseudodyskedema from the OCT films. So will a B scan be more sensitive in detecting a drusen when compared to an OCT? What is your?
So you mean an ultrasound B scan? So the good situation to use an ultrasound B scan is, for example, in a child that cannot sit still for long. However, you cannot be sure to pick them up. So if the drusen are too small and not enough calcified, you will not be able to pick them up by ultrasound. But if you're lucky to picking them up, it's a quick way to do it. You just cannot rule them out. So we did the comparison, and OCT is superior. Yeah. So yeah.
Okay. Any other questions? If not, may I? Oh, actually, yeah. Second, yeah.
This is for Ambika. My question was, you mentioned the study for Euro-MKit about low and high titer. What was the cutoff they recommended? I may have missed that.
I think they say any 1 in 20 or 1 in 40, they don't recommend for it. But Euroimmune, most of them do have a lesser dilutions only, I guess. And 1 in 100 is considered to be a better positive rate.
So you always, like your patient, you were sharing. I didn't see a titer mentioned. So do you always get a titer, or is it?
No, they don't give, because most of them do have a fixed cell-based assays. So they don't mention the titers when they give the reports. They just mention as it is positive or not. So that is the reason why that study will be more having a value, where we have to insist that we need a titer value when we are getting a MOG positivity.
Yes, I think somebody from Schroff, they were saying if you pay extra, they'll give you a titer.
No, because it's a fixed cell-based assay. I don't think there is a possibility of that.
Okay.
I doubt.
Okay, thank you.
I just have one question, if it's allowed. We have a lot of, Dr. Wong and Dr. Patrick, we have a lot of options for mutation-dependent and, like Idebenon and all this gene therapy for people who are mutation positive. But we have people who are clinically behaving like LON. They are negative for primary mutations. So do we have anything for that group of patients?
I think Idebenon also can be used in that kind of condition, and but not right now, not for gene therapy. Gene therapy is specifically
mutation
for
positive.
11778 and 3460 right now.
And I guess just one word on this is when it comes to these kind of clinical long diagnoses, right? One of the things that we've learned over the past few years is that we need to move away from just looking at the mitochondrial DNA, right? So it's quite clear now that you have a number of these nuclear genes which are behaving in a long-like fashion. So if you have access to next generation sequencing, I think it'd be worthwhile doing this, because you will find that there's probably now 10 plus of these nuclear genes. I think that will help in terms of the diagnosis, because obviously this has an impact on genetic counseling, right? So a good example of this is a mutation in the nuclear gene called DNA-JC30, which will not be very common in this part of the world, because this is a kind of Eastern European Slavic founder mutation. And in this case, Idebenon has very good results, really. So I think that is a good example where the genetic result can also give you a better prognostication, really, right? But this is different, as Professor Wang mentioned, for gene therapy, where unfortunately at this point in time it's like one specific gene replacement. But I mentioned this yesterday in the talk in the glaucoma session. We need to move away from mutation-dependent, mutation-independent gene strategy. And the way forward with this would be to look at these neurotrophic factors. For example, you could do BDNF gene therapy or your favorite neuroprotective protein, and then this would avoid you from having to go back to square one. So I think you're entirely right, Ambika, because ultimately, as Professor Golnick mentioned here, even if you have your right treatment, if this is going to cost $500,000, who's going to be paying for this?
Thank you.
So thank you so much. I think time is up. I think if we have any further discussions, we can continue it outside over some coffee. So at the end of the session, shall we call up all the speakers so that we can have a group photo and to conclude the session? So thank you very much for coming.